we have a lot of students here, and I'm thinking a lot of them probably at the level you were in 1987, in terms of thinking about their training, the things that they may want to do to sort of get at these issues. Do you have sort of recommendations for their training or experiences or sort of general thoughts about this?
Well, I would say I have some general thoughts and some specifics. And let me lay them out. It'll just take me about, 25 minutes. Scaring the dean. You know, the general point is that this has got to be a very big tent. So I would encourage students to look at what it is that they like to do. And I know that sounds very old school, but I mean, if you're gifted in basic science, you know, stay in the lab. This is obviously a conversation that many of us have had personally over the years. If you're gifted, if you're gifted in epidemiology, train in epidemiology. A couple of my students are really seriously contemplating training in development economics because they've seen me and all of us get caught up again and again in these very often bitter struggles over resources and an honest assessment of resources. I actually trained in a social science that I thought was relevant to the work, and I still do, anthropology. But I wouldn't recommend to my students that they go off and do what I did. I'd say find something you like, because you need to put in, as you said, 20 years into some of these efforts to feel that, you know, you're going to make a difference. So that's what I would say is broad tent. You know, find something that you'd like to do for someone, and then understand that this is really about teamwork. Anybody who says otherwise is, you know, doesn't understand the work. It requires, you know, huge teams of people. In the Rwanda project, as you know, but others might not, there are probably now 3,000 people working. Most of them have never had a job before. They are now community health workers. And surely 95, 96% of them are Rwandans, you know, or Congolese or someone from around that area. So these are big teams of people working together to break this cycle of poverty and disease. And you know, students who are now in their training should say, gee, I'm lucky I'm here in a place like this, you know, and take advantage of the kind of training that you could get here, whether that be clinical or in a discipline relevant to this work, and then be part of a team. Yes, sir.
First, thank you very much for being here and such an outstanding and provocative thought. And it provoked two very disparate questions on my part, which I'd love to hear you comment on. One will be, and feel free to evade or just, you know, dismiss this question, but seeing the zero oncologists in Rwanda and the zero oncologists in Haiti made me think about something that was implicit in that, but you didn't address explicitly, which is human capital.
Yeah.
You talked about community health workers, but there is a brain drain phenomenon that you're well aware of. Yeah. And then it juxtaposed with something that was really jarring to me that I just saw in the journal Academic Medicine, which I was just glancing through the other day. It was a little vignette by a medical student, and the person listed where they were, and they were in Saba, S-A-B-A, which is a small Caribbean island in the Netherlands Antilles. And there's a medical school there. And the whole phenomenon of offshore Caribbean medical schools, which are training often American, perhaps other students, not to say that this isn't appropriate, there may be many good reasons for it, but what a jarring juxtaposition that there are these medical schools in the Caribbean, and yet there's an absolute absence of human capital there at the level that you described. Any thoughts or comments about that?
Well, you know, I think some of the things we probably should not do, and I should have addressed this a lot more. To say there are no oncologists in Rwanda obviously doesn't mean we don't want them there. We love, but we want them to be Rwandan, you know. And so, how do you address the brain drain? And I would say, policing professionals is probably not the right way. Right? Say you can't do this, and there have been efforts to do that. I mean, to penalize the professionals who leave in search of, you know, more opportunity elsewhere. I'm not so sure that's a good approach. Anyway, it's not one that I would feel comfortable doing. So one of the things that we've tried to do is create conditions that are acceptable to our clinicians, living conditions, working conditions. And, you know, one of the things that strikes me is if you're a young physician, and a former student of mine studied this in Kenya, and you go into a hospital where say a big city hospital, in Kenya or any other place, and they don't have the tools that you need. And these people study with the same text that we did, so who can practice under those conditions? I would say no one can last long. It's hard enough facing this barrage of pathology, even if you do have the diagnostics and therapeutics you need. So I think that's a second point. One is probably not by trying to deny people mobility. I wouldn't do that. Two, create better working conditions, which also means having a there for the providers, that is the tools of their trade. And then, we need fair, what the local providers would consider decent compensation. And finally, training programs that, don't try to dumb down the curriculum because it's in another place. And those are four things I think we can do. There have been other models. As many of you know, Cuba has trained lots of physicians who have ended up some of them in Haiti, all over the world, like 35 countries. They're able to do that, I guess, because they can control the way the training programs go in the country.
Lack of freedom, right?
Yeah, I mean, there's a different, we're not going to do that in this country, and we're not going to do that in Europe. It's not going to be where you say, okay, we're going to repeg the number of physicians that we're going to train at. It's a very sluggish thing to do in most of the world. It's not going to be quick enough to respond to this wave of treatable or preventable pathology. That's why I keep on going back to community health workers. Because I think community health workers, even if you had all the doctors that you ever wanted and nurses, they're still going to improve the quality of care for any chronic disease. So they're unbeatable in terms of intervention.
I appreciate that. That may actually be a lesson for our own healthcare system, soon to be overwhelmed if we really provide access. But it leads me to the other just quick point and your thoughts about that. I thought it was brilliant characterizing this issue of Manhattan versus the Bronx in terms of the same kind of disparity issues. Some of the students probably won't know that until just the beginning of this year, it was not possible to get a liver transplant if you needed one in the Bronx, notwithstanding the fact that hepatitis C and other leading causes of liver failure are extremely prevalent here. And it's only the fact that our academic partner, the Montefiore Medical Center, opened a liver transplant program. And you could say, no big deal, you can go to Manhattan and get a liver transplant, but it actually is a big deal from a variety of points of view. But it really focuses, this brilliant focus on disparities, not to think of it in terms of global health, but disparities. And it's against that background that your comments about cancer are very striking to me. The vision that many of us who spend time in research in the lab have is of, quote, it's been hyped, personalized genomic medicine. And the idea that each cancer is a unique individual disease and that the state of the art will be sequencing the entire genome of that cancer to provide, hopefully, a very personalized therapy. So I wonder if you can comment. As I've thought about this, I've been acutely aware of the disparities in the United States. Imagine how difficult, and this is again the excuse that you so beautifully outlined, that should not become an excuse for not treating cancer or dealing with cancer in these areas of disparities. But your thoughts about this juxtaposition, that vision of highly tailored individualized therapy, and then the fact that you asked the oncologist here for what is the regimen for these.
Yeah. Well, I'll just say that, again, these are the sorts of questions that we come up against all the time in thinking about how to manage a complex disease like drug-resistant tuberculosis. You want to tailor the regimen not only to the drug susceptibility pattern of the infecting strain, but also, you have to tailor it in very complex ways sometimes to weight and kidney function, and it is just as complicated as what you described. And there have been a couple of responses that I think are not good. One is to say, as I've said here today, it's too difficult. Another is to say we have to have protocolized regimens. That's okay, as long as they're going to deliver fairly quality care. If it's a way of denying complexity, not a good approach. And third, and here's back to genomics, as I said, I think to be a Luddite about this, I didn't say this in those terms, but to be anti-technology in contemplating these problems is a big mistake. How many times have we learned that the tools that we have are going to come from basic science research? And we don't know the yield that we'll get out of genomic research or individualized or personalized cancer therapies, it might be huge for people living in poverty. In fact, I would assume that it has that potential. So I'm just not of that crowd that says, well, this is not a priority intervention. It's not at all clear to me that we'd have to choose between some of that work and work to address disparities in cancer risk and outcome in the United States. I don't think that's true. I think there must be ways looking at, I look at some of the ways massive amounts of public capital are marshaled for other, some would say more destructive enterprises. I think we can marshal more resources for investments that are going to have yield that we can't possibly predict here. So.
Quick question about here in the U.S., and the question has been raised as to if we wanted to advance the global health initiative within, at the very least, some academic medical centers, we could create fellowships in global health. Specifically, for instance, you've become an infectious disease specialist. We've created fellowships in cardiology, in obstetrics and gynecology. We've created fellowships in maternal-fetal medicine and endocrinology. And the question that comes to my mind is, number one, should we also at this stage start thinking in those terms? And what would it take to do such a project in order to move the agenda of global health within the academic institution that is somewhat more formalized?
Thank you, Dr. Duvivier. I would say it's absolutely imperative that we do this, and we do it now. Johanna mentioned in her introduction that we were able to start, a training program at the Brigham, which was the first global health residency in internal medicine. And I'm not bragging about that. It's way too small. I said to my coworkers when I looked at the applicants, I said, I just don't know how to participate in deciding how to narrow down this list. They're all fully qualified to be in this program. And the problem has been resources. It's expensive to train a resident, as anybody who has to do it knows, and it's also expensive to train a fellow to do it well. We figure that it puts on an extra year to the residency and costs about $200,000, maybe $220,000 per resident to do a good job. Meaning, to actually send them somewhere where they're going to be something other than spectators to poverty, you need healthcare infrastructure, you need supervision, you need collegiality, you need coworkers from that setting, whether it be in the United States or in Rwanda. All those things require some serious investments. So the fellowship program, which you mentioned, I think in a way we could do it a little bit on the cheap by marshaling together, some possibilities for, again, the irony here is a lot of our residents, when they're done, they're doing clinical work in the United States, not because it's what they want to do. Sometimes it is, sometimes not. Sometimes they're doing it because they have to earn a living, and that is completely understandable when you're trying to build something new. But in order to really push this forward, we're going to need some more federal financing of global health. Now, I would just argue that if this country is going to sink tens of billions of dollars into global health, which I think it should, obviously, it should also sink some resources into training American physicians or American-trained physicians about how to work as members of teams, how to understand that you're going to need to work with community health workers, how to learn programmatic. This is back to your question. You had to learn how to be programmatic doctors, program doctors. There's a lot of work that needs to be done, but it's hard for me to look forward and say, we're not going to need federal financing for this. And I think we need what are the medical schools doing? What are the medical schools doing? They're competing against each other for these resources instead of working together to increase the pool. And that has not been a very fruitful way to pursue global health, to compete with each other, in my view. To have malaria compete with, sarcomas, or to have oncologists to compete with infectious disease doctors or surgeons, or to have Einstein compete with Harvard. It's just not a good way to advance the cause. And so we need to pull together and say, we need training programs, and this is what they should look like. at the residency level, at the fellowship level, at the junior faculty level, et cetera. That's how you're going to build a new field.
Are there any consortium of medical schools from all over the world, France and England, that also have the same concerns as you're mentioning here, and that they train their medical students in the same way?
I think there are consortia like that everywhere in the developed world, in Europe, in Asia, in North America, in Latin America. I think the consortia are there. The next step would be to say, okay, let's be really rigorous with each other and say, what should these programs really look like if it's not going to just be a hobby for you? You know, you don't think of cardiology as a hobby or you know, surgical care as something that can be done without significant investments. And I would say, for example, looking at internal medicine and infectious disease, that means that you don't want to send someone off, as I said, to, say, a mountaintop in somewhere in southern Africa without any kind of support, mentoring, and above all, ability to provide care to the people they're seeing. And unfortunately, that's what happens now because, as you can imagine, with the way the last couple centuries of history have gone, there's rising tides of inequality, so that you have greater and greater concentration of wealth in some areas and less in others. And bridging that gap is very difficult and very painful to do. And when people who control resources in affluent continents and countries and settings, it's a bit of a hard sell sometimes, frankly. So yes, the consortia exists, but next step is, because they didn't exist 10 years ago, it's true, the next step would be really to be rigorous about the kinds of services that you'd have to provide and in what context, like, for example, the public sector versus a church group, how to bring those together. You know, in other words, would you give out federal funding if certain criteria were not met? And the answer is no, you would not. You would try to say, no, we need there to be a there. So step one is probably recognizing the problem of health disparities here and elsewhere. Step two is building these consortia and learning from each other. And step three is going to be, let's get some rigorous criteria by which we could judge the efficacy, really, of some of these programs for training in global health. You know, there's some universities and medical centers in Africa where it seems to me like every single university in the United States has a partnership project with the same universities. Can you imagine the administrative burdens on our African colleagues if they have to do even one report for all these different American universities and medical centers? You know, or watching in Haiti, you know, and you should think about this too. Imagine being in the Ministry of Health in Haiti or the Prime Minister and having to receive this endless parade of visitors, you know, with good advice but not a lot in the way of resources. So it's a very difficult arena, but it's one that we should take on. And if academic medical centers can't do it, then it's hard to imagine, you know, which American institutions could. Did I sound pessimistic? I hope I did not. I'm optimistic.
I have another question regarding the presence of zero-oncologists. From what I understand, some of these chemotherapeutic regimens can be very toxic and there's a lot of side effects. How have you dealt with treating these patients without the clinical knowledge of an oncologist at hand?
Well, you know, and I have to be careful in my delivery of this response because it can sound sarcastic, which is, as you can tell from my demeanor, is not my intention. The worst side effect, of course, is death. And that is the inevitable side effect of a wasting consumptive disease, right? So having heard this so many times around the other pathogens for which I was trained to treat, like drug-resistant TB or HIV disease, et cetera, that complaint was made all the time. How do you manage the side effects? Well, it turns out there are really not a lot of side effects with the ARVs. In fact, you know, I remember in the 80s saying, oh, no, you can't use that drug. It causes anemia. And you're saying, well, HIV itself causes much worse anemia. AZT will treat the anemia. Give them the AZT. So, you know, and then on it was with the anti-TB drugs. And, you know, Johanna was there for a lot of, actually, Marla Keller was a witness to this as well. So it's a very familiar line of argumentation to me. The second is it's not necessary to do it without an oncologist. Like Einstein, Montefiore oncologists could easily help people in El Salvador through the communication technologies we have now. We put together something called GHD Online, Global Health Delivery Online, where we had already 109 different countries participating, when people are asking very technical questions about management of side effects. And then the other thing I would say, so you don't have to do it without an oncologist. You just might have a remote oncologist who's in another town, city, or continent saying, okay, if you see this side effect, do this. And listen, it doesn't always work. I'm not saying that. What I am saying is the alternative is much worse, because if there's no oncologist and people are not ready to make a goodwill effort, then you know what's going to happen to the patients. And it's the same around difficult to manage surgical disease, right? Do you try to replicate cardiac surgery capacity in every district hospital? No. But you shouldn't do that in the United States either. Look at the Dartmouth Atlas and look at the variation in terms of quality of care in this country. And you know that some things are better left to subspecialty centers. But if there's none at all in Central Africa, or fill in the blank here, then we're going to have to find better ways to harness information technology. I mean, if as much energy went into managing side effects as into twittering about, celebrities, I think, you'd see that you could get a lot of information out the door that was really useful instead of stupid.
I'd like to draw you out a little bit more about the maternal mortality that you slipped in at the very end. In the first place, maternal mortality is a direct reflection of disparities in systems and in primary care. In the second place, there's a groundswell of interest among young people in addressing this problem.
Yeah.
They flock to training in the Bronx because they found an opportunity to do this first in the Bronx. And they flocking to our opportunities in global women's health because that's what young people really feel is a calling. In terms of fellowships, the history of fellowships in our discipline has always come from interest of some people to focus their interest and their clinical interests and their research interests, and the fellowships derive after the fact. And actually, they develop special interest groups, and then they're recognized, and then they declare themselves a subspecialty, and then finally the boards and the agencies that have to bless them acknowledge them as a formal subspecialty. The hook then is after all that, that's when we get funding to be able to train them. Yeah. So if we could just reverse some of those systems and those priorities, I think we can do a tremendous job in affecting maternal health around the world.
Well, I just would echo exactly what I agree with everything you said. I think that there are just a couple of things that, and I know you'll agree with them, but I would amplify a bit. One is that, as you said, maternal mortality is a very good report card on a system. Much better than enrollment of, in treatment for any chronic disease. Maternal mortality reflects a lot about the integration of prevention and care, about the quality of complex services, about follow-up, etc. So I'm all for it. That would be, if I were pushed to choose one indicator, that would be up there at the top of my list. A second point, as you said, a lot of young trainees are interested in this, and as well they should be. I mean, it's kind of an abomination, really, maternal death. And the fact that it varies so widely, not just in this country but globally, is another, terrible thing. If we can bring that agenda forward, which I think we can, then we could also strengthen the surgical infrastructure in general for surgical disease. So, if you can do a C-section safely, and you have the infrastructure, the blood banking, then you can also manage, perforated ileum. You can also manage, basic orthopedics problems. You can manage. There's a lot you can do in terms of addressing health disparities by using maternal mortality as, again, one of these vertical programs to drive forward improved systems. So.
I'm a new student of global diabetes in Uganda. And one of the things you were saying was about the prevention and care and the tension between them when you're working in countries. And I have to say, after my one trip with Dr. Hawkins, and we're going back again soon, that really is a tension because the Ugandan physicians will say, can you get us a laser for treating retinopathy? And meanwhile, we see that they don't have ophthalmoscopes or dilating drops in the clinics and don't know how to do the eye exams. And so I'm a behavioral scientist, so I'm thinking prevention. I'm trying to think, well, they don't have all the metformin they need, they don't have all the insulin they need, but there are certain things they can do to prevent complications, to prevent diabetes, in fact. We think maybe they can prevent it, maybe in the same ways we can, perhaps some kinds of their diabetes. And so I find myself thinking about prevention all the time. So what you said struck me, really, that it's so much more complicated and that the approach, even with just a little group, there were four of us there for a short period of time, with even just that it has to be multidisciplinary, multi-pronged, multi-component approaches, but then how do you handle all that when there's just a couple of you and just a little bit of funding, the prevention, treatment, tension?
Well, nothing that I can say will ease that tension significantly in the field, right? Nothing I can say here, but maybe, I would hope there's some way that I can ease your anxiety about thinking this is a new problem. This is a problem that is germane to all efforts to address health disparities. And what I would recommend is a couple of things. I'll be very pragmatic, and then I just go back to the large-scale sort of almost philosophical question you asked. In terms of managing a chronic disease, where you have a deliverable, whether that be insulin or metformin or some other oral hypoglycemic, I would be very cautious about trying to do that without community-based care, without accompaniment, without community health workers, because that's what happens. I talked to a couple of your other colleagues who were on that trip. I've seen this so many times. If it's called insulin-dependent diabetes, you're supposing it requires insulin to treat it, and I do, but you need, careful monitoring. And that can, instead of saying, well, we can't use insulin in settings like that, we have to say, all right, how would we monitor carefully? Community health workers. So that's one thing I would say. Invest some of those resources in, community accompaniment is one way of putting that. It's in community health workers. I think that'd be wise. Another is that you can't stretch. If the resources are too small, some of your time needs to be spent saying there are not enough resources for this. I would argue. And doing that without competing with some other natural allies. Like you wouldn't want to compete with those interested in reducing maternal mortality to say, no, actually, maternal mortality is not a priority, diabetes is. And that's what happens a lot in our field, is people are competing for the same pie, when in fact the pie needs to be larger, right? And I think to bring the entire weight of the medical community and scientific community to bear on a problem like this, I don't think we haven't seen a consensus statement on diabetes in rural Africa yet. I haven't seen it. Maybe it exists already. No. What's that?
There is actually an IDF statement for sub-Saharan Africa.
Yeah. Well, I've seen some of the other statements which have the disadvantage of being incorrect. In other words, they basically resign themselves to defeat, saying, well, I showed you them today. Well, taking on cancer in the developing world, you really can't do it. Just focus on prevention. That's not going to galvanize the hearts and minds of patients, family members, healthcare providers in Uganda. To say, you know what, we can do an MRI, but you really shouldn't even be thinking about that. I'm not talking about diabetes anymore. But I think that's not a very fruitful line of. So I would actually try to get them the lasers. at the same time that you're involved in efforts to make sure that ophthalmoscopes are available in all these clinics for poor people. Like, I don't know the epidemiology of diabetes in Kampala, but I would imagine, you know, it's a little different from, say, even across the border in Rwanda, or in rural Rwanda, where I've been mostly in rural Rwanda. I haven't seen a lot of diabetes, and the kind we've seen has been, you know, this insulin-resistant diabetes that seems to be more prevalent in and I'm not sure what the latest thinking is on this third type of diabetes. It used to be called Z-type, tropical diabetes, J-type. So, you know, I would just caution you that discouraging your peers from learning the latest technologies, I don't think that's going to be a great way to make them love having you back there all the time. You know, and I've seen it too many times in my work where we say, well, you know, you can't do, and I'll just go back to the two examples. One would be, let's say MDR-TB. If I were to say to my colleagues, you know what, you really shouldn't focus on thoracic surgery, on resection. It's really not appropriate to this setting. That would have been a non-starter for a lot of my colleagues, certainly in Peru and Russia, where there were more thoracic surgeons in Russia than you could shake a stick at. I mean, everybody and his mother was a thoracic surgeon. So it wasn't a good opening gambit to win the confidence. HIV to say, you know what, we'll never be able to do a genotype on HIV here. I wouldn't say that. And I didn't, and we do not. You know, do we have a way of doing genotypes on lots of specimens? No. It's like with dry blood spots, which is a PCR technology, you know, to determine whether or not infants were infected. We piloted that in Haiti over the objections of some public health specialists, who were only too happy to say that that was not an appropriate technology for that part of the world. So these are just, I'm sharing, you know, again, in a way I hope to remind you that that was your first trip, it sounds like, and, you know, you're in for, you know, a bumpy ride. It's not easy to face disparities, but it's probably better to face them than to not face them. And the disparities are not just around ophthalmoscope laser, it's, you know, who has enough food to eat, who's eating too much, et cetera. And how much those should be the topic of our discussion, I don't know. One last thing about prevention of diabetes. Let me advance a hypothesis, since you're behavioral science. You know, they probably say this here as well, but I remember when I was in medical school at the Mass General, someone said to me, ask a pizza man what's for dinner, he's going to tell you pizza. So ask a behavioral scientist what's for dinner, they're going to tell you prevention. And I'm also trained in that arena a little bit, but I would say that it's hard for me to look at the diabetes epidemic in the United States and say that we have really effective interventions, population-based interventions. It's very difficult to say, because I think what we can say is local and regional disparities are reflected in differential burden of disease. And, you know, you look at, you know, you look at, you know, Native Americans, and on and on. The disparities are not, yes, you could say they're related to behavior, but they're also related to things much deeper than behavior, like history and political economy and what happened and destruction of cultures, and on it goes. So it's probably very wise to be careful about claims of causality regarding, you know, diabetes or any other pathology. So I would keep doing what you're doing, which is go there, be open-minded, work with colleagues, you know, find ways that do no harm to intervene. I think that's still a pretty good approach. I applaud what you guys are doing.
As someone who's involved in Einstein's federal relations efforts, could you tell me a little bit more about what you may be doing personally to pry loose some money from Washington? Have you met with the Obama administration? If so, what have you told them? And then second, are you doing anything to actually push forward this consortium idea of pulling universities and colleges together to pry loose some more federal funding for global health?
Yes, no, yes, yes. Yes, we are, and we have, and we will continue to speak to the administration. I think that I would actually, in addition to try to pry loose money and find the right mechanism, whether that be, you know, Department of Health and Human Services, the NIH, et cetera, I would also say global health has gotten to be such a big consortium that it's better to break it down a little bit also into, allied interests. Like, for example, training at going back to Dr. Duvivier's question, I think residency and fellowship training are different and then, say, global health at a university or a medical school. They require larger and more intensively focused streams of research. So I think for a consortium, for example, if you have a consortium of surgical residency programs who are saying, we want to make this as, I'm just curious, how many of you are interested in surgical subspecialties as careers? So, including obstetrics. If you were to say, we are a consortium of, instead of 152 American universities and medical schools interested in global health, but we're a consortium of 9 surgical training programs with serious commitment to introducing global health curricula, then that isn't a bad thing. You're not competing with, a liberal arts college you shouldn't be competing with a liberal arts college for funding for global health if you're willing to do training of, and then again, psychiatrists or, internists. That's what we did. What we did was say, let's build these sub-consortia as well, not just of universities interested in global health, because now you'd be hard-pressed to find a single American university that doesn't say they do this. At least I haven't seen any. But there are very, very few training programs at the fellowship and residency level. And a lot of people who are in medical school, most of them are going to do residencies. So we're in a medical school today. Now, if I were at a college, I might say something else. But, I think we need to pull together consortia, not just of medical schools, because there are some. I know there was just a meeting, I didn't go to it, but also to have a deliverable for the feds, too. And it's hard to know for sure what the deliverable is. I think training programs is a big one.
This has been a wonderful thing. We have one last question, and this is actually, you're being picked up by, I guess, your chief of staff.
I have a chief of staff?
I guess. So here we go.
Hi, so I'm a student here, and I'm really happy to have heard you speak. It was really great. So as a student, I've seen a huge increase in the interest in global health just as long as I've been a medical student here. And a lot of the people sitting right next to me have gone abroad over the past summer as part of Einstein's Global Health Fellowship program. However, my question was that I think a lot of the programs that we work with have, and other global health organizations have problems with sustainability. A lot of the programs we worked with for 2, 4, or 6 weeks.
Yeah.
And I think that's a lot of students. That's really all we can afford to have in our schedules. But what do you think about those organizations, and how can we find organizations to work with that are sustainable and work with the community?
Can you just give me an example, and then I'll focus my response on specificity?
So an example would be, this past summer I worked with a group called Amazon Promise in Peru. And so we would go up the river, for 2 hours, work in a village for a day, and then leave. And maybe this village will not see another group or a charity organization for another year, if that.
Well, I just want to say again, and as I was saying about diabetes, I would be remiss if I didn't say to you, take that as the beginning rather than the end, and because one of the things you said is, how can we find organizations that are sustainable? And I would say it's too bad for a group, if they're doing good work, to be dismissed as unsustainable. I know this from personal experience, all right? Life is not sustainable, all right? And I don't mean to be, as you can see, I'm not being flip about it. I'm just saying, I would say to someone your age, don't give up on a worthwhile effort because it isn't being done properly yet. So it's not that what you describe is unsustainable, because obviously our abuse of that part of the world, of the Amazon, is also unsustainable. That's what I read, and my daughter tells me that. I believe it. So what is it that's not sustainable about what you describe? Probably our using up of natural resources and our dividing ourselves into people who can travel, as you did, to the Amazon, and people who won't see a doctor for another year. That's what's unsustainable. And so getting the diagnosis of what's unsustainable is the inequalities and disparities and destruction of, really the planet. Now, what you describe is also poorly planned, clearly. If you're going to deliver services 2 days out of 365, it's not well planned yet, because it involves a lot of air travel, and I don't want to say this in a bad way. I want this to be the beginning of the conversation. Like, if you would look at, again, this is something that I learned from my 11-year-old, is what would the carbon footprint of that effort look like, right? You get on a plane, you fly all the way to South America, you get in a boat. I assume it wasn't some cool biodiesel boat. And you go deliver 2 days a year. But I would say, let this be the beginning of a reflection, not the end. So that's called a short-term medical mission, right? You are training, you take it you're a med student right now. You're training in medicine. And you're bound to this place for your classwork, for your rotations. You'll probably train, I hope you do train, in an American hospital, in a specialty of your choosing. That's a good thing to be able to do too. So you have to do short-term medical missions, as you say. Finding good partners who are delivering high-quality services to people regularly in a place like that, part of it is going to be making sure that everybody in this room says, we got to move some of those resources back down there so that our partners are sustainable, because it's clear that people living in those areas need some services that people like you or me or others here could offer. So that's one thing. Now, you're not going to be able to do that remotely from the Bronx. You're not going to be able to, rebuild an NGO based in Peru from there, or, build up. But you can. So you also need to find good partnering institutions for you, and part of that is going and doing what you did. It's like going to Kampala for the first time. You're going to find out a lot about the problems facing those who are interested in the prevention and care of diabetes. Same thing for you going there. And I wouldn't underestimate the value to you of that experience. Because to be able to be fluent about short-term medical missions in, what year are you? In your second year of medical school, it's not something I saw very much 20-something years ago, 25 years ago when I was in med school. But now I actually have a lot of students who are very up-to-date on the strengths and weaknesses of short-term medical missions. So I'm just saying, don't feel that, it's a bad thing for you to have been one of the chief beneficiaries of that short-term medical mission. I think that's okay, especially if you get involved long-term in this kind of work. So again, I want to end on that optimistic note that having your generation involved in this in a serious manner, in a critical and reflective manner, is going to be one of the best things that we can see come out of this whole global health movement, if that's what it's been. So thank you, is what I'm saying. Thank you.
Thank you very much. Well, that actually closes the morning. Again, to remind you, we do have something going on in the afternoon. And for those of you that are a bit peckish, before that starts in the afternoon, there'll be a little bit of food out in front of Price. And that's the Price Auditorium in the new building across the street. Thank you all for coming. And thank you, Dr. Farmer.